Don't forget to do that. So schedule-wise, we moved 25 to tonight, pediatric. So we'll start with pediatric emergencies, and then we'll move to chapter 26, which is geriatric emergencies, and then chapter 27, which is special populations and situations. And then next week, you guys are on your own with 700. If you've done that already, you're good to go. Just send me and Jules your certificate. Let's chat. Okay, perfect. Kevin will pop on a little bit here. And then the following week, we'll finish up 28, 29, and then the 24th, finish with 30 and 31. Then we'll be done with the book chapters. So, all right, so I'm going to stop sharing on that and then get going on chapter 25. This one. All right, let me hide some of this. Make this bigger. All right, so chapter 25, we talked about OBGYN and that stuff last week, so this kind of follows those chapters. So this one is going to be pediatric anatomical differences. Determine the age of the pediatric patient. Sometimes it is hard to tell how old people are. Communicating with them, proper equipment to use, the pediatric process, which is a PAT triangle that we'll talk about, and then our assessment of pediatric patients. Respiratory emergency care, shock, trauma. It's all a lot of it's the same as the adults. Special healthcare needs, sudden infant death syndrome, and child abuse and neglect. We'll talk about that stuff. So pediatric patients can be among the most challenging patients for lots of different reasons. Communication is different with them. We have to be aware of some of the differences in anatomy and physiology as compared to adults, like they have a bigger tongue, a bigger head. On a positive note, pediatric patients a lot of times present with signs that make identifying acute problems pretty easy for us to identify. So anatomical differences when it comes to pediatric patients. Some other pediatric differences, so supporting the head of an infant, and we talked about that a little bit. Before 9 months, an infant cannot fully support their own head, so just make sure that we're supporting their head. Sudden movements can cause neck injuries in that age bracket. Be aware of the fontanelles, like I talked about, between the unfused cranial bones that haven't fused together yet of the skull. There's one anterior, one posterior, so there's two on top there. We can examine or treat the head of an infant gently. Be aware of those fontanelles. An infant or small child, they have large heads. So when we're lying supine or we have them on their back, a lot of times their neck is hyperflexed. So accounting for that when we're opening the airway or performing a spinal immobilization. So we can put something like a blanket or something behind their shoulder blades that will keep their head kind of in line. So instead of it being kind of hyperflexed up, if we put padding back here, it kind of brings their head up and forward, kind of more symmetrical. We want to stop bleeding quickly in this age bracket. Small volumes of blood loss are pretty significant, more so than like us. Extremity injuries can damage growth plates, so that can affect their long-term growth of that extremity. If they have like a broken arm or broken leg, it affects that growth plate, so they're worried about that. A pediatric patient's skin surface is large compared to the body mass that they have. So they're more prone to hypothermia, and that's why, and they're more prone to dehydration than the adults are. Their response to burn injuries also is more severe because of that larger skin surface. So that's why we're worried about hypothermia and burns in infants and younger patients. Determining the age of a pediatric patient. So sometimes it's important to know the age of a patient when we're providing care. A parent or caregiver can usually tell you the age of that patient because they can't talk. When we can't determine the exact age of the patient, just use your best judgment. When a child is in a stressful situation, remember that they might act younger than their age. It can make it difficult to kind of assess and provide care for that. So when possible, ask the parent or caregiver to find out if the child is reacting to the pain or the stress of the emergency as one might expect, or if they're reacting differently. Can kind of change their age a little bit. Currently, the age parameters for an infant are from birth to 1 year. For a child, they're 1 year to the age of puberty. Signs that a patient has reached that puberty usually includes facial hair, chest, underarm hair in females, and breast development. So some of the developing characteristics we talked about in the lifespan development chapter. Again, infant, that's um, your birth to 1 year old. So they're gaining 6.6 pounds per year. They're sleeping at a rotational. They like to have a schedule, all that fun stuff. Toddler age is when they're starting to get into recognizing the consequences of right and wrong, kind of the cause and effect situation stuff. That's like your 1 to 3 preschoolers, or your 3 to 5 age bracket, where they're starting to kind of wean off from the parents because they're going to like daycare or kindergarten. And then you get into the school age child, which is that 6 to 12 age bracket area, where again the peer groups are getting bigger. They're striving for their independence. Adolescents are like the tough age. Things can be embarrassing. Just dealing with them kind of individually, so their friends aren't standing around. You're going to get more out of them. So just some of those developing characteristics in these age brackets, it's good to know. And if you want to know more about that one, revert back to that lifespan development chapter that we talked about as well, because we went through all of those characteristics there. Communicating with the pediatric patient. So we're going to be with them when they're ill or injured. Obviously, that's why they're calling us. When we arrive on scene, our presence alone as an unfamiliar person can add to what that patient already perceives as kind of a frightening situation for them. And that is a common and completely appropriate reaction for them to have. Often the presence of an unfamiliar person is going to add to that stress of that patient. So children often take cues from anxiety level of the provider. So just stay calm. That's going to help calm them down a little bit. When we're examining children younger than 10, consider positioning yourself at their eye level, not staring, including them in your conversation because they want to be a part of that. We're not going to make sudden movements, and we're going to ask their permission before we touch them when we do anything. When we're examining adolescents, we want to be sensitive to their feelings of modesty. Also consider their concerns about permanent disfigurement that we talked about in that lifespan development chapter. And then be aware again that they are sensitive to that peer pressure from their group. Always consider the well-being of the family when a child is ill or injured too. Explain interventions, things that we're going to do when appropriate. Involve the family members when appropriate. If the kid wants to sit on mom's lap, totally fine, do that, as long as it's not interfering with our care. So stay calm, keep on the child's eye level, don't stare at them, sudden movements, ask for permission, and then seize the moments when the child is cooperative and you can get stuff done. You might have to talk them through stuff like, you're going to take a blood pressure. Well, what is that? Well, I'm going to put this on your arm. It's going to squeeze it a little bit. Or if you're going to get an O2 sat, you want to put the little monitor, their pulse ox on their finger. I usually show them what's going to happen, and then I do it to them so they kind of understand what you're going to be doing. Talking them through some stuff. And again, adolescents, be sensitive. They're very sensitive to that peer pressure. So might not be able to get answers out of them for sensitive questions. So again, even if their parents are around or their friends are present, maybe ask those sensitive questions when nobody's around, or put them in the ambulance. Be like, we just want to check you out in here, get a better environment kind of thing. Or if you can move people out of the room, do that. Caregivers, when dealing with pediatric patients, parents and caregivers may be very upset and concerned. So there's a few more common responses like crying, emotional outbursts, anger, guilt, confusion. Don't take any of those responses directly toward at you personally. They also need support and understanding during those times because it is kind of emotional when we're dealing with kids. During the assessment, explain to both caregivers and the child what you're doing. If appropriate, ask the caregiver for assistance in caring for the patient. Most children will be more comfortable and cooperative if they're being held by a parent sitting on their lap, something like that. We may encounter a parent or caregiver who will not let you help an ill or injured child. That person may insist on being in control of the situation. In those cases, avoid becoming defensive, even though the parent may be coping in the only way they know how to do that. ultimately the child is our patient, and if we were called there by them, that is our patient. So we don't want to delay stuff that's an emergency as well. We can get law enforcement involved if we need to. Some techniques for dealing with these anxious parents or caregivers: protect the health and safety of the patient. So if parents are making unsafe demands, we can try an approach of reserved confrontation, explain the assessment and care being provided is based on a sound medical knowledge and that their demands are obstructing what is appropriate and in the child's best interest. Realize that the parents may be offering sound advice as well. They do know that child better than anyone. Regardless of the parent's behavior, treat them with courtesy, respect, and understanding. Remember that they want to help, so try to stay positive. Let parents stay close to the child as long as they're not interfering with care. And if appropriate, they can be held by that parent. Never react to anxious parents with anger. We're not yelling at people. We're dealing with the best we can. Again, you can always get law enforcement involved if you think, especially if it's like an abuse situation or something like that, and you're getting the tingly feelings. Equipment-wise, a lot of it's the same. It's just smaller. So using the appropriate size pediatric equipment is important. One size doesn't fit all. This big oral airway is not going to fit in an infant, right? So we want to follow state or regional requirements for pediatric equipment. Usually we carry in the ambulance anyway, we carry a separate pediatric bag that has all the smaller sizes of stuff in it: smaller blood pressure cuffs, smaller oral airways, smaller nasal airways, that type of stuff. BVMs, all that stuff is a little bit smaller. So having the right equipment in the correct size is extremely important to deliver that quality patient care. Again, one size doesn't fit all. There is a wide variety of equipment size in order to fit the needs of patients to ensure that we have the right stuff. You guys probably won't be dealing with a ton of pediatric patients in the field that you're going into, more geriatric. So just know that there is equipment out there that it's the same as the adult, it's just smaller in size. All right, the pediatric process. So assessment is the cornerstone of providing good patient care. Correctly identifying the patient's presenting problem leads to correctly treating that patient. With children, much of the assessment can be done, which they say is from the doorway. The caregiver may provide information to you as well as emotional support to the child. Children differ from adults. They become unstable in a very short period of time, unlike adults who we can kind of tell when they're starting to deteriorate a little bit. So we want to continually reassess pediatric patients. They'll be good, and then they'll just crash on us pretty quickly. So using the view from the door, the patient's general appearance, their status of breathing, and skin color gives us as first responders a great deal of information about the patient's status and need for urgent care. Like usually you can walk in and be like, that patient's pretty sick. Often a parent or caregiver can be helpful by providing assessment information about the events leading up to what was, our reason being called, and any medical history that kid might have. The status of a sick child can rapidly deteriorate, so we want to constantly reassess if they're critical. So from the doorway assessment means just looking at the patient's appearance, their breathing quality, and their skin color as soon as we enter the scene. Always ensure that the scene is safe. We're going through our whole thing: scene safe, mechanism of injury, nature of illness, additional resources, etc. On pediatric calls, that means making a mental note of how the child is interacting with their parents or caregivers. Pay close attention to the health and safety of the environment that kid is in. Be alert for medicine bottles, chemicals, alcohol, drug paraphernalia. We are mandated reporters, so if there's any possibility of child abuse in that environment, we're just keeping our head on a swivel with that, just to make sure that kid's in a safe place. So from that doorway assessment, we're going to use what's called the PAT triangle, pediatric assessment triangle. So this uses their appearance. How do they look? Are they awake, alert? Are they sitting, like leaning forward, drooling? Are they laying in bed, not moving? Their work of breathing, and the circulation to skin. So how do they look? How are they breathing? What does their skin color look like? Are they normal color? Are they pale blue? What are they? So with the appearance part of it, when assessing this, we're assessing muscle tone, interactivity, and consolability. So questions that we can ask ourselves: is the patient limp or listless as opposed to moving around spontaneously? A floppy or limp child really indicates a serious condition typically. Is the patient alert, responsive to verbal stimuli, responsive to painful, or unresponsive? That's our AVPU scale, like alert, voice, pain, unresponsive. And then when a parent tells you that something is not right with the child's mental status, it's a clue that something probably is wrong because they know that kid. Most children who are sick, particularly the very young, can usually be consoled by a caregiver. When a child cannot be calmed by a caregiver or does not respond well to the parent, it's usually a red flag that they're in some kind of pain or discomfort. Abnormal appearance is an important clue of significant serious illness or injury. So how are they looking when you walk in? The work of breathing, each side of this pat triangle is connected. So if we observe the patient seated in that tripod position, like legs crossed or bent over in appearance, also indicates difficulty breathing. Indications of an increased work of breathing or difficulty breathing. They'll have abnormal breathing sounds like wheezing, which is usually like asthma. Stridor, which is usually an upper airway obstruction. Maybe they're choking on something. They put something in their mouth. Grunting, was there a respiratory distress? Are they using those accessory muscles to breathe? Those retractions. Usually it's like mid-clavicular around the collarbones, intercostal around the rib area. And then nasal flaring. Is their nose kind of flaring out? Or they have pursed lips? Are they having a difficult time breathing? And then the last side of that triangle is circulation of the skin. So just signs of abnormal circulation. We have pale skin, which is poor perfusion. Cyanotic skin, which is inadequate oxygenation, or are they flushed? Exposure to heat, maybe they have a fever, that type of thing. So what's their skin color look like and condition? So again, that's our PAT triangle. That is our appearance, work of breathing, and circulation of skin. So most life-threatening problems in pediatric patients have to do with airway and breathing issues. Your highest priority is to ensure the patient's airway is open and that they're breathing adequately. Remember that the child's head is large in comparison to the rest of their body, so putting a pad like a towel or a blanket underneath their shoulders in order to adequately open the airway and keep it open. If we suspect trauma, we're going to open the airway again with the jaw thrust maneuver as opposed to the head tilt chin lift maneuver. And that's used for non-traumatic patients. Once the airway is open, ensure adequacy of them breathing. As respiratory effort increases, the signs and symptoms change. The patient will be using accessory muscles initially, then respiratory rate will increase. As breathing gets worse, their muscle tone and cyanosis is going to start to be present. So again, looking at that PAT triangle, what are we looking at? So placing something behind their shoulder blades is going to get them, instead of this hyperflexed, it's going to get them more of an inline neutral position that they call the sniffing position. Signs of respiratory distress include noisy breathing, like wheezing, stridor, that kind of fun stuff, high-pitched seal barking, which can mean like epiglottitis, other things, cyanosis, nasal flaring, retractions, accessory muscle use, breathing with obvious effort, extreme breathing rate if it's like really fast or really slow, or alter mental status. At a minimum, a child who shows signs of respiratory distress, regardless of how minor it is, should be getting oxygen if they're breathing adequately. If you identify any time that the breathing is no longer adequate, we're going to get the bag valve mask out and start bagging these individuals. So indications of breathing difficulty include wheezing, stridor, grunting, use of accessory muscles, all of that. If they look like they're just struggling to breathe, obviously they're having a breathing issue. If respiratory distress progresses to respiratory failure or cardiac arrest, we're going to ventilate the patients. Indications for ventilating children, an infant with a respiratory rate of less than 20. So infant is not a newborn. Infant again is that after that 24 hours up to a year. So if the respiratory rate is less than 20 per minute, we're going to ventilate them. And if a child with a respiratory rate of less than 10, we're going to ventilate that child. With infants and children, hypoxia or lack of oxygen causes the heart rate to slow, and then cardiac arrest can occur. We're going to palpate the brachial artery of the infant. That's the one that's under your arm. For the responsive child, we're going to palpate either radial or brachial pulse. If a child is unresponsive, we're going to go right to the carotid, just like as an adult. So if you have anybody that's unresponsive, adult, child, we're going right to the carotid. Infants, always brachial, the one that's right on the inside of your muscle and you're under your arm. With infants and children, again, hypoxia causes the heart rate to slow. So we'll be thinking we probably want to put oxygen on these kids. Indications for beginning compressions for this age bracket. No pulse. Obviously, we want to start compressions. And then for infants, if it's a pulse less than 60, we would want to start compressions on them. So when assessing circulation, we also want to look for any bleeding, stop any bleeding immediately. Children have the ability to compensate for blood loss longer than adults, but they decompensate at a really fast rate. So that means the heart will rapidly lose its ability to maintain sufficient circulation of the blood. So if they're bleeding at all, we want to get it to stop. We do our sample history. You guys remember what that one is? Signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events leading up to the situation. Additional questions we can consider, like when did that start? When did the signs and symptoms start? Have they progressed? Is this a reoccurring problem that they've been having? Has the child seen a physician lately for the problem? What is their diagnosis if they have one? Have they been receiving treatment for that? So other questions that we can ask as well. For trauma, this includes the time of the incident, the mechanism of injury, and the emergency care given before we get there. We always want to start with asking open-ended questions, try to avoid the yes, no right away. We can ask some of those, but we try to start with, what's going on, what happened, and then kind of proceeding from there just to kind of get a timeline started and see what's going on with the kid. During your assessment, we need to expose the child to identify additional injuries, just like we would do an adult, the head to toe. Remember that children are more prone to hypothermia, so don't just go stripping them down. We want to keep the patient warm by exposing only the necessary things and then covering them back up as we go when we do our head to toe. We want to cover their head up to prevent heat loss. So some tips for completing that physical exam on kids. We want to leave the child in the parent's lap if that's appropriate. Be calm and reassuring. Get on that eye level with them. Describe your actions and what you're going to be doing. Talk to the child directly. Be gentle and don't lie to them. Ask permission before you touch them. Like, I'm going to, grab your finger. Can I do that? I'm going to check your foot. Can I do that? I'm going to look at your belly. Can I do that? Restrain only when necessary and imperative for that treatment. And then gain the child's confidence by offering them something to distract them. Maybe there's a toy laying around you can get them and they can start looking at that while you're doing your head to toe. Have the mother or father talk to them, etc., etc. So assessing the following, looking for injuries, we're looking for dots, right? Our deformities, open wounds, tenderness, and swelling. So we're going to look at the head for bruising or deformities. We're looking at the eyes for any drainage. Also looking at pearl, pupils equal and reactive to light. For the pupils. Mouth, looking for loose teeth, unusual odors, bleeding. Neck and spine, we're looking for injuries like bruising or deformities. Chest and back, we're looking for bruises, injuries, rashes that they might have. On extremities, looking for any deformities, swelling, pain, going through our dots mnemonic. So we're doing our head to toe. And if it's appropriate, in some children, you might have to do a toe to head, starting at the toes, working way up if they're really young. That would be another way to do it as long as you're kind of hitting all those points. Change in vital signs can occur quickly in children. When taking vitals, we want to look at their pulse. So assess the brachial artery for infants and radial or brachial artery for a conscious child. Again, if they're unresponsive, an infant would also be brachial, but a child would be carotid. Respirations, we want to monitor for a full minute to determine the rate and quality, making sure that it's got the rate that we're looking for, and also like what's it feel like? Is it weak? Is it thready? Is it bounding? Is it normal? Is it irregular? Blood pressure, be aware of late indications of shock. So if their blood pressure is starting to go down, again, that's a late indication of shock. Skin temperature and condition, feel the arms, legs, and the torso. Again, if they're hypothermic, their abdominal area with the back of your hand is going to give you the best kind of if it's cool to the touch, they're definitely hypothermic. Skin condition, assess for pale, cyanotic skin, injuries, what's going on with their skin condition, and then capillary refill. Refill of less than 2 seconds may indicate shock as well. So looking at their hand, you push down on it. If it's not coming back super fast, that could indicate hypoperfusion as well, or shock. Respiratory emergencies, how we care for these. So once we identify a respiratory emergency, we got to take immediate action. We need to be pretty aggressive when it comes to kids and airway. So difference in anatomy and of a child's airway can impact the treatment. Children are more susceptible to respiratory problems. They have smaller airway passages and less reserve capacity than we do as adults. They have a smaller airway. A child's airway can close off if the neck is flexed in or extended back too far. So we want to, again, pat under the child's torso or their shoulder blades to manage that airway. Because of the immature respiratory muscles, children sometimes use their diaphragm to breathe. So you're going to use it, like see their belly kind of breathing. We call them belly breathers. Children's tongues take up more space in the airway. Using manual techniques make the tongue remain off the back of the airway. So our head tilt chin lift or our jaw thrust is going to move that tongue out of the way to actually open the airway up. Infants and children tend to breathe through their noses, so suction their noses if they're congested with mucus. Only suction for short periods of time. We try to do 10 seconds for a child, 5 seconds for an infant. Provide oxygen before immediately after suctioning so we don't drop their respiratory rate. So have oxygen ready, suction ready, all of that before you start. Infants would be with typically, you can use this on children too, but we usually in our pediatric bag, we have a bulb syringe that we would use for that. For bag valve masks, so children, again, more susceptible to respiratory problems, airways, smaller diaphragm breathers, larger tongues in comparison to the airway. I kind of talked about this. They're nose breathers. When we're using a BVM on an infant, or child, just remember we want to do it so we just get chest rise. We don't want to like blow their lungs completely apart. So we want to do it just enough to get that chest rise and fall on our breathing. So pediatric sizes, they come in bag valve masks come in 3 sizes. They come in adult, child, and infant. So the reserve capacity in those bags just keeps getting smaller, obviously, as the age brackets get smaller. All right, some of the stuff people can have. Croup is a very common viral upper airway infection. It's most common in children between the ages of 1 and 5. They're going to have like a high-pitched breathing noise or hoarseness. Swelling progressively narrows that airway down, which causes that high-pitched breathing. The child may become hoarse and have kind of a seal bark kind of cough. Some signs of respiratory distress in those children. As it gets worse, they may exhibit some of this, a decreased or an increased breathing effort, their body's trying to get oxygen in. Accessory muscle use, so midclavicular and intercostal muscles. Pulse rate is high, respiratory rate is high. They could be pale or cyanotic because that oxygen is not getting where it needs to go, which then leads to altered mental status because our brain, again, is sensitive right to oxygen. So severe attacks can be dangerous. About 10% of all children with croup sometimes are hospitalized. So we do want to treat this as respiratory distress in our patients that have croup. So again, that seal bark, kind of high-pitched bark cough or hoarseness kind of is part of this one. Epiglottitis, this is a bacterial infection of the epiglottis. Again, that's in our kind of our windpipe, our trachea area, right? Thanks to vaccination, it doesn't occur often. If left untreated, it can be life-threatening. Some signs and symptoms. This child is going to be anxious and concentrating on their breathing. They're probably going to be sitting in that tripod position and drooling because it's painful to swallow. Changes in voice quality. They're going to have a fever with this one because it is an infection. It's itis. So itis is an infection. If we suspect this, we want to keep the child calm. Don't ask them to open their mouth. Don't examine their throat. Don't put down anything down their throat. Actually touching the larynx or their voice box can actually cause the airway to completely swell up and close. So it's kind of a scary situation when it comes to epiglottitis. But provide care for a child as you would any other respiratory patient. So oxygen, if you have to do blow-by oxygen. If you're suspecting epiglottitis at all, if you're leaning forward in that tripod position, drooling, etc., they got a fever, be very careful with examining that one. Asthma, this is very common. Depending on the severity of the attack, it can be a very serious condition. When attacks occur, the bronchioles spasm and contract, which is what narrows the airway down. Because remember, the bronchioles are in our lungs. It's like the bronchi, bronchioles, and at the end of the bronchioles is those little alveoli sacs. That's what we need for that exchange to take place. The bronchial membranes begin producing excessive mucus, which further narrows down the airway. They're not getting as much oxygen that they need. They can't get the air out. They can't get the air in. So they're going to have rapid breathing. They're going to be pale and cyanotic. Again, that's that bluish grayish color. They're going to be wheezing. Wheezing is a big one with asthma. Significant wheezing can be heard without a stethoscope. You're going to hear it when you walk in. So as the condition gets worse, wheezing may subside only because the child is no longer moving air and producing that wheezing. So don't be fooled like, oh, they're getting better. They might not actually be breathing very well. So again, oxygen, ambulance, when they get there, they're going to use a nebulizer with albuterol. So if they have something like that in the house, we could maybe have the parents start that. Emergency inhalers, stuff like that. Cardiac arrest in infants. So most cardiac arrest in pediatric patients is a result of an airway obstruction and respiratory arrest from an underlying medical condition or trauma. Ensuring an open airway and adequate breathing in your patient is our highest priority when dealing with pediatric patients. So signs and symptoms of circulatory failure is an increased or decreased heart rate, unequal central or femoral and distal pulses. So if you're feeling a radial pulse on their arm and carotid pulse and they're different, that would be a sign. Poor skin color, such as paleness or cyanosis, delayed capillary refill of less than 2 seconds, altered mental status. In cases of cardiac arrest in children, we want to perform CPR for 1 minute before we call for help, unless we're already on the phone with help. Children have remarkable recuperative abilities. We're not going to stop CPR until relieved by whoever's coming in behind you with the ambulance. For use of an AED, we want to follow AHA or American Heart Association guidelines for that. Ideally, we would use an AED designed for pediatric patients, but we can use an adult AED that is accepted. A pediatric version is not available, but we'd have to put the pads posterior and anterior. So instead of putting the pads right shoulder and right abdominal area, we would put one on the front and one on the back so they don't overlap. But we can use an adult AED on a kid. Seizures in this age bracket, they have what's called febrile seizures. These are seizures caused by a rapid rise in body temperature, usually resulting from a high fever. Their fever spikes and they go into a seizure. Other causes of seizures include infections, poisonings, trauma, or hypoxia. Get a history. Maybe we can ask some questions like, has the child had a seizure before? Is the child's normal seizure pattern if they have? Are they epileptic? Do you know what are they been diagnosed with something? How many seizures has the child had in the past 24 hours? What was done for them? Has the child had a head injury, a stiff neck, or a recent headache? Do they have diabetes? The stiff neck part could be meningitis. Are they taking any seizure medications? Could the child have ingested any other medications? What did the seizure look like? Did it start at one part of the body and progress? Did the eyes go different directions? I would ask them how long it lasted. If it's over by the time we get there, or when did it start, so you can kind of figure out how long it was. Are they having one right after the other? So questions we can ask as seizures, just like an adult, except in kids, it could be caused by a spike in temperature, which is a febrile seizure. So position the patient on their side to allow for drainage, kind of let them have their seizure, right? Protect around them. Same thing we would do as an adult. When they're done, position them on their side for drainage of the airway. Don't put anything in their mouth. Don't restrain them. Place them in an area where they're not going to strike an object or injure themselves. Loosen any clothing that's tight. After the seizure, open their airway. Prepare to suction the airway out. High flow oxygen by a non-rebreather mask would be good. We can hold the mask slightly away from them until the seizure is over so we can start getting them oxygen while they're actually having a seizure. If breathing is adequate, we're going to leave the non-rebreather mask on the patient. And if it's not adequate, we're probably going to have to get the bag valve mask out and start bagging them to get them some oxygen. If the seizure lasts longer than 5 minutes and reoccurs without a recovery period, again, that is that status epilepticus, just like an adult, and that is a life-threatening condition. So we want to kind of know when it started, when it stopped, how long it lasted, what it looked like, kind of when we get there, if it's been done. All right, so shock. Children compensate for shock longer than adults, but then they start to tank very quickly. So signs and symptoms of shock, again, altered mental status, delayed capillary refill, rapid or weak pulse, pale, cool, clammy skin, falling or low blood pressure, absence of tears when they're crying because they're dried up, they don't have anything else to give, a dry diaper that should be wet. Infants, the fontanelles on top might be sunken in a little bit. Hypothermia can intensify shock in an infant, so we want to keep them warm. And caring for the pediatric patient is shock is the same as the adult. So we want to lie them flat on the back in the supine position, provide oxygen, cover them up with a blanket, monitor their vital signs, kind of package them up for transport. For trauma, injury is the leading cause of death in infants and children. Blunt trauma is more common than penetrating trauma. Basic life support for traumatized children is similar to the adults, so we kind of treat as we go with these, just like we would an adult. If they're bleeding, we want to stop the bleeding. If they have a broken leg, we splint it. So we begin the assessment of the ABCs, airway, breathing, circulation, correct any problems that we see with that after we identify them. Suspect trauma with significant mechanisms of injury. If a small child is injured in multiple vehicle collision but restrained in a car seat, we can leave them in that car seat and immobilize them unless the seat has been really damaged. It's not fully intact, but if it is, we can leave them in that seat because it is restraining them. And we want to continually reassess the patient for signs of deterioration. So anything that we would do on an adult for trauma, we're gonna do on this age bracket as well. Special healthcare needs. So children who have some special types of physical or mental limitations have special healthcare needs. Many of these children are receiving home care. They attend school. They participate in activities throughout the community. You'll see them around. Most parents or caregivers have usually received training on how to deal with emergencies in regard to the healthcare need that they have. When EMS is called, usually it's a true emergency beyond what the caregiver or parent is comfortable handling, or an urgent problem with that the parent or caregiver is recognizing that they need to go to the hospital for. Most parents or caregivers of children with special healthcare needs have received that training on how to handle the emergency for their particular patient or kid. So as a result, they can kind of be an important resource for us when we're doing our assessment and care because they kind of know what's going on. So don't just dismiss parents in this situation. So when treating the special healthcare patients, focus on the ABCs. If the patient is on a ventilator, it is more important to disconnect it and ventilate the patient with a bag valve mask and determine what's wrong with the ventilator. Okay, if the ventilator is not working, we can detach it. We know how to use the bag valve mask and breathe for that patient. Hook it up to oxygen. It's gonna be the same thing. Caregivers or parents are very good resources of that information about the child's condition, their baseline vital signs, their medications that they're taking, how to operate that medical equipment. Additionally, they may have dealt with a similar problem in the past, so always enlist their help when we're treating a child. All right, SIDS, sudden infant death syndrome. So sudden infant death syndrome is defined as a sudden death of an infant in the first year of life with no identifiable underlying causes. SIDS cannot be predicted or prevented. In fact, it's still not really well understood. They are getting there to the point where it's maybe like a suffocation type of deal. But SIDS almost always occurs when the infant is sleeping. The infant is typically healthy and was born prematurely between the ages of 4 weeks and 7 months. The infant dies without warning. No illness has been present, though some have had some cold symptoms. The extreme emotional impact associated with SIDS makes the patients or the parents victims just as much as the baby is. So in addition to standard BLS treatment, thorough history should be obtained as well on where was the baby in the crib, was there anything else in the crib, etc. So managing these calls can be a lot. We're going to begin resuscitation if rigor mortis is not present. Tell the parents that everything possible is being done, but don't give them false hope. We're never going to say, they're going to be okay. We're going to say we're doing the best we can. Obtain a brief history. When was the child put in the crib? What were the circumstances concerning the discovery of the infant? What was the physical appearance of the infant in the crib when you found them? What else was in the crib? What is the condition of the room and the home that you're seeing? After EMS arrives and assumes care, we're going to encourage the patients or the parents of the patient to accompany them to the hospital. We may experience emotions of anxiety, guilt, anger. Dealing with pediatric patients can be a lot sometimes. Debriefing or talking to a counselor, coworker, medical director, your boss can be helpful. So denying any of those feelings can negatively impact your mental health as well. So just take care of yourselves as well. All right, child abuse and neglect. So child abuse is defined as improper or excessive action so as to injure or cause harm. Child neglect refers to giving insufficient attention or respect to a child who has claim to that attention and respect. If we encounter abuse, we're not going to be judgmental. We're going to focus on providing care for that child and transport to the hospital. And we'll talk about what some of the signs and symptoms of this are. So non-accidental trauma occurs in all parts of our society. The estimated number of children who are abused or neglected in the U.S. is staggering. Estimates range from 500,000 to over 4 million cases annually, with thousands of abused children dying. During the call, the adult who abuses the child may be behaving in an evasive manner. He or she may offer little information or give contradictory information about what happened. Just focus on providing care to the child and transporting them out of that environment. Some signs and symptoms include, let's go over some of these. So some of the stuff that you'll see is like multiple bruises, patterns of injury that don't match the mechanism that they're telling you. Cigarette burns, whip marks, handprints, untreated burns. We also want to suspect abuse when there's multiple calls to the same address. Caregivers or parents seem inappropriately unconcerned, or they give conflicting stories to us. If you're getting kind of the willies with it, maybe you should say something when you're done with that call, like pass that on. Children who seem to be afraid to discuss how the injury occurred because the parents are standing there. If an infant presents with unresponsiveness, a seizure, or signs of severe internal injuries but has no external signs, that's when we're suspecting central nervous system injuries, which is shaken baby syndrome as well. Signs of neglect, lack of supervision, malnourishment, unsafe living conditions. They have a chronic illness that's gone untreated, like asthma, but they don't have any medication for it. A delay in reporting the injury. These are different things that are considered neglect, which is eventually leading into abuse. All right, if we suspect abuse or neglect, ensure the scene is safe before we enter the house. Provide emergency care to the patient. Pay close attention to that environment that they're in. Complete a full assessment as you would for any other patient. Update EMS as usual. Always transport that child to get them out of that environment. Don't confront the parents or caregivers. If you're not comfortable with them being with you, etc., get law enforcement involved if we need to. Maintain confidentiality. And then we are mandated reporters, so you have to report suspicions of child abuse or neglect to the proper authorities, which is passing that along to either law enforcement or the nursing or the EMTs that are there, and they can take it and pass that along to the nurses and doctors as well, just to get that reporting process started. All right, so pediatric patients, patients who are infants or children, the pediatric assessment triangle, or PAT, is a method of remembering the important components of pediatric assessment. So we go with appearance, breathing, and circulation. Retractions, sucking in between the ribs above the sternum and above the clavicles. So if you see any of that, they're having a difficult time breathing. Croup, again, is a common viral infection of the upper airway, most common in children between the ages of 1 and 5. Epiglottitis is a bacterial infection that inflames the epiglottis, often resembles croup, but is more serious than that. Febrile seizure is seizures caused by a rapid rise in body temperature, usually resulting in a high fever. SIDS, sudden infant death syndrome, is a sudden death of an infant in the first year of life with no identifiable underlying cause. Child abuse is improper or excessive action so as to injure or cause harm to the infant or child. Child neglect is insufficient attention or respect given to a child who has claim to that attention and respect. Non-accidental trauma are injuries caused by abuse. Shaken baby syndrome, again referring to an infant or child presenting with unresponsiveness or seizure or signs of severe internal injuries but no external signs, causing suspicions of a central nervous system injury due to shaking of that child. So lungs of children are more easily damaged by trauma because their ribs are more flexible. they're not like fully rigid yet. There's a lot of parts in kids that have to kind of fully come in. Like their trachea is a little bit, it's not as bold as ours. Everything, that's why they choke kind of more. Everything's soft, and you gotta kind of grow into that. Which of the following is an early sign of respiratory distress? So using the accessory muscles to breathe. So that again is going to be like mid-clavicular, intercostal muscles between the ribs, the sternal area. And if you see any of that, that is they're having difficulty breathing. Three sides of the pediatric assessment triangle, or the PAT triangle, is our appearance, how do they look, our breathing, and our circulation. So that's D. And the last one, when responding to a call where child abuse or neglect is suspected, which of these guidelines should be followed? We don't want to confront the parents. We will still do a full assessment, right? We don't want to focus attention on the parents or ask the child to recreate the situation. We just want to do our full assessment and get them out of that environment. All right. Questions so far?
None for me. I think everybody else is pretty decent unless they're speaking up.
All right. Okay, that was the longest chapter we have for tonight. So let's go to, that was 25. I'll go to 26. Get rid of this one. 26, share that screen with you. All right, 26. Now we talked about young people. Now we're going to talk about old people. These are the geriatric patients, the older age brackets. So physical changes and challenges, psychosocial and economic factors, and illness and injury to these older adults is what we'll talk about with this one. This is kind of the group that you guys will be seeing. Hopefully you watched that video. I think it was a good video that I posted on your email on Monday. Just kind of shows the progression of like these people come in, they're like, we have no idea what's wrong with them, even though they're presenting the same as like our age bracket is. So intro to this, we're going to encounter many older patients in emergency situations. You guys will be dealing with a lot of this age bracket in the business that you're in. So you're going to find these patients in different environments. A lot of times they're at home alone, which is where you guys are going, with family members in their homes, retirement communities, assisted living facilities, nursing homes. So when dealing with pediatric patients, we have to adjust the way you would ordinarily provide emergency care to adult patients. For instance, if an elderly patient with kyphosis, it's like they're kind of hunched over, right? You've seen them kind of hunched over, their heads down. If they fall, injures their hip, they're not going to have a good time laying supine on their back, right? They're going to be kind of up. So we have to kind of figure out ways to deal with these patients and package them and that type of stuff. So we have to alter some things and think outside the box sometimes. Additionally, elderly patients may often have multiple medical conditions, right? They could have high blood pressure, a stroke history, cardiac history. It's all kind of combined. So getting a good history and completing a good assessment to understand what their current problem is and why they called, on top of like what's your past medical history, right? All this other stuff could be part of this currently. So always treating elderly patients again too with dignity and respect. If we respond to a resident and it's obvious that their condition of their home, the patient maybe shouldn't be living alone, seek assistance for the patient by reporting our findings, obviously to the proper people as well. Maybe they shouldn't be in that environment anymore, and that's a hard thing to do. We're going to commonly deal with elderly patients who have diminished hearing and mobility, so we want to take some time to handle them appropriately. Be an advocate for them. So try to do the best you can for these guys. Physical changes and challenges. So the most common theories about age related to the genetic makeup, the environment, our individual lifestyles, whatever the underlying cause, all body systems start to decline with age, which becomes a contributing factor why these older geriatric patients become ill or injured. Aging causes a general decline that includes changes in our skin, our sensory organs, our respiratory system, our heart, our blood vessels, our digestive area, the urinary area, musculoskeletal injuries occur, nervous system, So the central nervous system, strokes, immune systems, UTIs. Age results in weakening of the chest muscles, and that's a loss of capacity in our lungs, so it's harder to breathe. So as a result, elderly are less able to compensate for challenges that require more oxygen demand as well. Um, Aging changes the body's ability to respond to and eliminate medications. This can result in an exaggerated response to medications and profound side effects for them. So there's a lot going on in this age bracket to think about. As people age, they develop darker pigmented spots in their skin called age spots or liver spots. The skin secretes less oil, makes it drier and flakier. Skin secretions also contain substances that assist in fighting infection. When the skin secretions decrease, the patient again is more prone to infection. Perspiration decreases with age, affecting one of the body's mechanisms to rid itself of excessive heat so they can get hot quicker. So they're more prone to these heat-related emergencies. Some medications also inhibit perspiration, further affecting the patient's mechanism to control body heat. I know my mom deals with that. She sweats all the time from this pill that she's on. If a geriatric patient is in shock, they may be presenting with, they're not going to be presenting with those typical signs of diaphoretic skin just because they can't, like we do as like younger adults. The skin of some older adults tears easily as a result of loss of fat and weakening of the supportive tissues in their skin. So they get like soft skin where you touch it and it can rip. Often elderly patients will get skin tears if we don't handle them gently, so we don't want to cause any more damage to them. The breakdown in the skin is also a contributing factor for bed sores, which can have devastating consequences in these older patients, especially on their heels, their butt, their back, that kind of thing. If we're not rotating them or if they're laying in one spot too long, they can get those sores, and that's a big deal for them. Sensory organs, aging leads to a decreased sharpness of the senses. Visual changes include farsightedness, cataracts, decreased night and peripheral vision, and less tolerance to glare, like night glare. These changes make reading more difficult, including reading of the medication bottles that they might be taking, which can lead to medication errors and accidental overdoses. Visual decline also contributes to injuries like trips and falls. Hearing becomes less acute, especially in hearing high-pitched sounds. Elderly patients also have a decrease in sensation and cannot feel pain as they should. So they might have like a 4 out of 10 pain when it's probably an 8 or a 9 if they have a broken hip, a normal person or a younger person. A decrease in the sense of smell may lead to elderly people eating spoiled food because they can't smell that it's not like that's spoiled, so they eat it anyway. Diminished senses of taste and smell contribute to a decreased appetite, and they start having nutritional problems, which endangers the overall health of the individual as well. Sounds fun to get old, right? Respiratory system-wise, aging results in weakening of the chest muscles and stiffening of the cartilage between the ribs, the intercostal area, which makes breathing less effective. An elderly patient also has a decreased ability of their lungs to provide oxygen to the blood, which is where that exchange takes place, right in the alveoli. Changes in the elderly patient's lung and immune systems make them more prone to developing respiratory infections like pneumonia. Heart and blood vessels, all kinds of things changing, right? So with age, the heart has a decrease in its ability to contract and forcefully as it should, like to push out the blood. So that leads to a decrease in output of the heart. The body attempts to compensate by increasing the heart rate. If the heart rate increases too much, it loses the ability to actually fill that chamber to pump out the blood. It's pumping out like half of what it should. Again, that results in a more profound decrease in output. Many older adults have high blood pressure that can lead to heart attack, stroke, and kidney problems. Significant blood loss will also cause a drop in blood pressure. However, if the patient has a high blood pressure, their blood pressure may still be within normal limits. So I usually ask these older patients, like, what's your normal blood pressure? A lot of times they'll know. Or if I tell them their blood pressure, they're like, that's pretty low. And then you ask them, are you on a blood pressure medication? Did you take it today? So there's things in this age bracket that are happening. A lot of things at once, typically. Keep a patient's normal range in that mind during your assessment. What is normal that you're seeing isn't actually normal. It's probably not normal for them. Genetic and lifestyle factors contribute to changes in blood vessels over time, blockage or weakening of the arteries that can lead to heart attacks and strokes. Good times in our heart and blood vessel area. Digestive system, this decreases secretions that aid in the breakdown of food. This, along with other changes, lead to indigestion, gas production, and constipation. Since the stomach empties more slowly, vomiting may occur during illness or injury. Elderly patient may also suffer from ulcers or disorders of the intestinal tract, leading to bleeding. This is where like the GI bleed would be coming from. The bleeding may be evident in their vomit or dark tarry stool. So if they're pooping and it's like a dark coffee ground appearance or bright red in color even, or if they're vomiting that, this blood loss can be significant enough to lead to shock in this age bracket. So if we're seeing any of that, we should be calling 911 as well with your patients. That's not normal. Urinary systems. Elderly men may have a blockage of the urine flow due to an enlargement of the prostate gland, making kidney and bladder infections more likely. Elderly women are more susceptible to UTIs or urinary tract infections. Elderly patients with a UTI can become very ill. Their overwhelming infection may cause a change in their circulation that can lead to shock. That type of shock is called septic shock, kind of all over in their body. So if we suspect a patient has some signs and symptoms of shock without the blood loss, especially if they have a fever, they're probably septic, and they should be going to the hospital to get checked out. So providing emergency care to septic patients as we would any other shock patients. So oxygen, lay them on their back, keep them warm, get them to the hospital to get checked out. That can be a pretty serious condition, obviously. Musculoskeletal system, as age increases, the bone decreases in mass and strength. Because elderly patients are more likely to fall and have weakened bones, they are a greater risk for fractures, arms, legs, hip, the femoral head. That's where we see a lot of these breaks, shoulder injuries from trying to stop themselves. The nervous system, decrease in nerve fibers and changes in the chemical balance in the brain can lead to a decreased perception, with changes in balance and coordination and altered sleep patterns. Some believe the impairments in thinking and memory, referred to as dementia, as a normal process of aging. However, that is not the case. Age may be a contributing factor, but most elderly patients you encounter probably don't suffer from dementia. As elderly patients' current condition is more likely a result of the illness or injury. If somebody has like a UTI, they can be very out of it, very mean. Their personality totally changes, and once they get treated for that UTI, urinary tract infection, they go back to kind of their normal state. It's crazy how much a UTI can affect these older patients. Immune system. So common illnesses like the flu have a higher mortality rate in this population. Though fever is a sign of infection, it may not be present in the elderly. In addition, the increased risk of skin infections or infections in general and a decreased ability to heal after an injury or surgery may be more serious and even fatal for these patients, like staph infections and that MRSA, that kind of thing. As we age, the body's ability to respond to and eliminate medications changes. Elderly patients may have an exaggerated response to medications and more profound side effects as compared to younger adults. Since older patients are often on multiple medications, they have to consult with their doctor when starting a new medication to prevent a life-threatening drug interaction from occurring. Polypharmacia happens quite a bit with this, trying to figure out how to take all these medications that maybe don't get along with each other. Psychosocial and economically, so many psychological, social, and economic factors impact the lives of the elderly. Yes, they're alcoholics. Yes, they can use drugs. Physical and psychological abuse happens, neglect, loneliness, living in poverty. All of those factors have implications for health of their population. So being aware of them is a step toward developing empathy and compassion for this age bracket. The clues that these issues are out there kind of help us provide follow-up treatment as well. Being a good advocate for that patient, kind of pushing that forward so people know what's going on in their home lives. Making sure to communicate what you see and hear so that can be passed along. So we're often, as a first responder, we're seeing them in their homes. The doctors aren't there to see what's going on. So we're a vital link in detecting psychosocial issues that affect the well-being of these patients. We can suspect abuse if any patient whose injuries are inconsistent with the history given or mechanism of injury. Financial concerns often affect geriatric patients' ability to care for themselves and may be a significant component of their ongoing medical condition as well. Depression is common among the elderly, loss of independence, loss of a spouse, loss of friends. Having to depend on others for care often leads to depression. It can lead to suicide or attempted suicides or suicidal ideations. In fact, suicide rates are very high in this population. Be alert to what the patient tells you about their significant life changes. While depression can be treated with medications, depression is a lot of times undiagnosed in this age bracket. Substance abuse. Healthcare providers often fail to recognize substance abuse as a factor in medical condition of the patient. This may include dependence on prescription medications like pain meds. Some elderly have illegal substance abuse problems. People that were in their 20s, 30s in the 1960s, that was kind of an illicit drug use time, was pretty popular, right? Now they're in their 70s or 80s. So drug use could have continued throughout their life. Alcohol and substance abuse contributes to the deterioration of their physical health. It may be a factor in altered mental status and a contributing factor to some of the traumatic injuries that they're facing. So that is a thing out there. Often first detected by us, right? We can pass this along, what you're seeing in the field. We should suspect abuse when injury is inconsistent with the story, multiple injuries in various stages of healing, just like child abuse. Reluctance to discuss injury in the presence of others, maybe like at the nursing home, they don't want to talk about it in front of the CNA that's there or whatever. Unkept patients or their environment is unkept. We don't want to confront the abuser. We just want to kind of note that, treat the patient, get them out of that environment. We can figure out what's going on. Socioeconomic concerns. So many older adults live on a very limited income or fixed income. So as a result, an elderly patient may not have the money for adequate shelter, food, safety, or medications that they need to take. Lack of adequate heating or cooling of a patient's home makes them susceptible to heat and cold-related emergencies, hypothermia, hyperthermia. Elderly patients with financial concerns may not eat properly. That results in malnutrition, or may not be able to afford the required medication, which leads to the deterioration of their medical condition. So these are some reasons people are doing what they're doing, is because maybe they can't afford it. Stuff is expensive. Illness and injury. So common medical complaints of the elderly patients, chest pain, difficulty breathing, fainting, altered mental status, which could be stroke, could be diabetic, could be seizure. We want to consider some of these serious, right? Especially chest pain. Difficulty breathing may occur due to lung or heart conditions or an airway obstruction. Maybe they're choking. A patient who faints or experiences near fainting episodes should be evaluated. When an older patient has an altered mental status, a family member or caregiver usually summons help. The common mechanisms of injury for elderly patients are falls, burns, motor vehicle collisions. These are all usually due to the effect of aging, diminished vision, loss of strength, balance. Sorry. To show respect, first speak directly to the patient. When the patient is speaking, always consider communication issues like poor hearing, glasses, dentures. Make sure there's enough adequate lighting in that room as well. Use family members to help establish a baseline for this patient for your assessment. Like, is this normal for them or is there something off? They're going to know. Consider psychosocial factors when conducting a patient history, or you guys will know, right, as caregivers, when you're out there, like this patient's acting different today. You're going to kind of know when this was happening. Are there issues that might influence the patient's answers? Maybe there's somebody standing around they don't want to talk about. Is the patient afraid of the cost of medical care? Is the patient afraid of leaving a pet behind? I've actually had to give insulin to a cat once just to get the person to go to the hospital. So, I mean, it happens out in the field. We can do our scene size up. Our first priority, again, safety, as always. Altered mental status in the elderly is not uncommon, and patients can become violent. Be alert for signs of abuse or neglect. Watch for potential hazards like loose handrails, damaged stairs. An elderly patient may not be able to maintain their home. If the patient has signs of carbon monoxide poisoning, look for alternative heating sources like space heaters that they might be using to save money. Observe the patient's hygiene and the cleanliness of their environment. When approaching an elderly patient, focus on the patient, not the family member. They're your patient. This demonstrates respect for the patient and gives them a sense of control over the situation. Make eye contact with them, get on their level, address the patient by their full name. We don't use like dear, honey, sweetie. You can say their first name or Mr. or Mrs. I usually call them by their first name. Allow the patient time to understand what you're asking them. Don't bombard them with questions. So give them time to answer you back. Speak aloud so they can hear you, but not shouting because then they'll yell at you. I'm not deaf. Right? It will happen. Perform a primary assessment as you would any other patient. So general impression, what are you seeing? Mental status, that's our AFPU, alert, voice, pain, unresponsive. Checking their airway and breathing, check their circulation. Immediately correcting the life threats that you're seeing there. If they need oxygen, put them on oxygen. We'll get the physical findings. The secondary assessment for these patients is the same as the other ones. We want to perform our physical exam. If it's a medical patient, we're going to be doing our OPQRST and sample. Looking at that specific thing that's going wrong. If it's trauma, we're going to do our head to toe, figure out what else we're seeing that we're missing. The elderly are usually cold, even in a warm environment, so they may be wearing multiple layers, which makes physical exam kind of a little bit more difficult to perform. So we can assist the patient in taking off some necessary stuff and maybe covering them with blankets when we're done, or lifting and moving things so we can see what's happening. Be alert for the presence of medical identification jewelry because this may give us clues also to what's going on if they have a necklace or a bracelet on, or an anklet or a tattoo. Gather your sample, your OPQRST, right? I don't think they go through that one again, but our OPQRST is our onset, right? P is provocations, OPQ is our quality, how is it feeling? R is our radiation or region, where's it at? Does it go anywhere? S is our severity, our 1 to 10 scale, and T is our time. And then getting our sample. If the patient exhibits altered mental status, determine if that's current status is normal or is that abnormal. So ask the family, is there something different going on? Maybe that patient had a stroke in the past and this is where they're at right now. This is their new normal. Or is there something else going on? An elderly patient may deny signs and symptoms of illness or injury because they fear the cost of medical care, ambulance transport, possible admission to the hospital, because maybe after the hospital they don't go home. They maybe end up in a nursing home. They don't want that to happen. They're also afraid of leaving behind spouses, siblings, pets, that type of thing. The patients may also only have a vague complaint like nausea or weakness. That can actually be a heart condition, right? So this can be a true emergency, pretty serious, and they can be ill with just those vague complaints. An elderly patient may also again be taking multiple medications, so get prescription bottles, look at them for yourself, see if they're taking them as prescribed. Look at the pill bottle. If it was just given yesterday and the whole bottle's gone, we have a problem, right? Elderly patients who are injured or ill are likely to show a slow and steady decline in their condition. So stay vigilant, don't become complacent. Take multiple sets of vitals and observe in trends in order to provide appropriate care for these patients. This is that future of geriatric emergency care by Dr. Jason Greenspan that I sent you guys. If you haven't watched that, please watch that. Terms, diaphoresis. This is excessive perspiration. So if we say somebody's diaphoretic, they're sweaty, pale, cool, clammy. Cataracts. This is the opacity of the lens of the eye, the most common cause of blindness in adults, and they can get that corrected. A lot of people have cataract surgery. Alzheimer's disease, a progressive degenerative disease that attacks the brain and results in impaired memory, thinking, and behavior, the most common type of dementia in elderly. And then dementia, this is loss of brain function that results in a person having impaired memory, disorientation, decreased judgment, and lessening intellectual ability using a progressive process. All right, so which of the following is a contributing factor for heat-related emergencies in elderly patients? This one is a decrease in perspiration. They're not able to sweat anymore. Which of the following conditions is common in the elderly and makes breathing less effective? Becomes more rigid. They have this. but weakening of the chest muscles allows less air to get in and out. Which of the following is a risk factor for abuse among the elderly? This one I didn't really talk a lot about, but loss of bladder control. If you're in a nursing home, especially, and your depends aren't being changed, that's going to lead to other issues as well. So that can be part of the abuse cycle. Which of the following is the most effective way to communicate with an elderly patient? Yell at them, right? What's wrong? Tower over them. No, position yourself at eye level so they can read your lips or look at you in the face. All right. Questions on geriatrics, the people you're going to be dealing with for the most part, right? Nothing? Okay. All right, so let's do 27. So this is special populations and situations. I move this little bar up. There we go. That go away. So special populations and situations. So this one we're going to talk about technological advances, special patient populations assessment and care, our physical impairment care, medical devices, abuse. So this one, like today's modern world of medicine, allows a lot of people to stay at home with special needs on these assisted advanced medical equipment devices that we're like have no idea how to use, right? So responding to an emergency care of these patients is no different than responding to other patients. However, they may have some complicated pre-existing medical conditions that we have to consider. So these patients and their caregivers are often very familiar with the conditions that you're going to encounter, and they can provide you information for what is normal and what is not normal for these patients typically. So technological advances. Advances in technology have increased the number of patients with special healthcare needs who are living at home. With more patients with special healthcare needs living at home, we're more likely to encounter this in the field if you're going out like as a first responder or these unusual medical conditions. We can do our best to familiarize ourselves with the special healthcare needs of patients in our response area, but we have to remain flexible enough to adapt to unusual circumstances that we don't anticipate because some of the stuff is like, I don't know how to use any of that, right? But some of the stuff we do. So it's allowing more people access to medical devices and care outside of the hospital environment, which is great for them than traditionally just providing hospital setting stuff. So patients who are previously unable to survive at home are now able to do so. As a result, we're likely to provide service to these patients with these devices and conditions that were previously not encountered by us as first responders. So these calls may be for a problem with the patient's medical device or totally unrelated to the device at all. But we're going to encounter these patients with special needs in a variety of locations, personal residences, nursing homes, especially at rehab centers, specialized healthcare centers. Taking your some time for yourself to familiarize for these areas in your response area and these facilities that you have, it would be a good idea. We are going to encounter these patients using these portable devices. So talk about what some of these are. So assessment. So often nurses, CNAs, or family members who have been trained to care for these patients accompany a patient with these special needs. They'll be with them. These individuals become very familiar and comfortable with specific equipment that is needed by these patients. Some general questions that we can ask when we get there, like, has the problem ever occurred? What fixed it before? Have you or anyone else present been taught how to fix it? And if they haven't, like, we don't know what to do with it, right? So if, like, they're on a ventilator, we can take them off and we can bag vote mask. There's certain things we can do in the field. Have they tried to fix the problem? If they tried to, what happened? Just enlist the assistance of the caregiver to be part of that solution to the present problem because they're going to know how to deal with it. They can provide advice and issues ranging from how to best move the patient to troubleshooting the medical devices that they're on. So they deal with the patient all the time, so they're going to have that advice on how to get them from the chair to our cot, etc. So we can assign a team member to work with that caregiver while we start patient assessment as well. So congenital diseases or conditions is one that's present at birth. Some common diseases and conditions that we may face include congenital heart disease. This is the most common birth defect. The heart and large vessels of the heart are malformed when they're born. Cerebral palsy is a neurological disorder that causes developmental disabilities. And cystic fibrosis, this is a lung disorder that causes difficulty breathing as the patient ages. So these are diseases that are present at birth in our patients. So that's congenital. Acquired, these diseases occur after birth and can be caused by exposure to a virus or bacteria. They might also be caused by trauma or a medical condition. So some common acquired diseases and conditions that you'll see out there is chronic obstructive pulmonary disease, that's COPD. Essentially, that's chronic bronchitis and emphysema is the chronic obstructive pulmonary disease. Human immunodeficiency virus, or HIV, acquired immune deficiency syndrome, that's AIDS, and then brain or spinal cord injuries secondary to trauma or medical conditions like stroke, which would be the traumatic brain or spinal cord injuries. End of life and terminal illnesses. So as a first responder, we're going to encounter patients with terminal illness. Many of them have a DNR order or other palliative care orders. DNR is the do not resuscitate. They might also have a DNI, which is do not intubate. Many times palliative care is provided by hospice organizations, which you guys might be working with some of those. Hospice is a community-based organization that provides palliative care to terminally ill patients. The goal is to provide the most comfortable environment possible for that patient. When a patient dies under hospice care, many times the hospice nurse is there to deal with that death. If the hospice nurse is not present at the time of the patient's death, the family is going to call 911, and that's when we're going to be called out. When you arrive on scene, they should present you with that DNR. In most states, as a first responder, we can honor that valid DNR and withhold resuscitation efforts. However, laws that govern DNRs vary from state to state. So Minnesota, we honor DNRs, and whatever else state you go to, you should look into that. Patient may also have a living will or other type of advance directive to provide direction to the family member about their wishes after they pass away. All right, physical impairments. So we may encounter patients who have some sort of physical impairment. They can range from those affecting the patient's senses, such as sight or hearing, to those affecting the patient's functioning, like paralysis or developmental disabilities. They can also range from patients who call EMS as a really wide variety of impairments that affect hearing, sight, speech, all of that. So I carry a notebook around with me, and I've had to use that on certain patients that are hard of hearing. I just write it out, and they can say what they mean. Take extra time to help the patient adjust. If it's not a true emergency that you're at and you have some time, take some time. Remember that these impairments don't affect their ability to think for themselves. They're just taking their time to do it a little bit to process it. Each limitation requires a different approach and consideration when treating the patients. Like say you have a patient with poor vision and furniture has to be moved during the call. If it's appropriate and you have time to do so, return that furniture to its original position because that changes the layout of their home. So we don't want them tripping over stuff when they get back. If a blind person has a seeing eye dog, or if a deaf patient has a hearing dog, federal law under American with Disabilities Act, or ADA, allows that patient to bring that dog in an ambulance as long as it is not a threat to others. So people have brought their pets with them. Physical impairments may limit one aspect of ways in which a patient interacts with their environment. However, the patients may adapt very well to those limitations. So consider adaptations when communicating with your patient. So again, hearing loss is more common in the elderly, but it's not restricted to older populations. Anybody can have hearing loss. Many patients with hearing loss can read lips, so you should talk normal volume and speed. Yelling or trying to speak more slowly makes it more difficult for them to understand you when you're talking. If you cannot communicate with the patient, write down your questions on a piece of paper. That's why I carry a notebook. So get a piece of paper out, start writing stuff down. They'll start yelling back at you. Mobility-wise, difficulty walking or standing is a problem for many elderly. However, problems can occur at any age. Carefully assess the patient's ability to ambulate, which means walk. If they're non-ambulatory, they're not able to walk. Ambulatory means just they're able to walk. Determine whether the patient requires assistance by using a walker, a cane, a brace, and so on, stuff like that. A patient in a wheelchair may be difficult to assess. The patient will probably not be able to stand, so we should assess them in a position of comfort, but try to do as thoroughly as we can. Mobility impairments may create difficulties in that physical assessment state. We also have gait belts we can put on people and help them walk as well. All right, tracheostomies. And I'll talk about this coming up. This is not a tracheostomy in this picture. Okay, this is a G tube, but we'll get there. Tracheostomy, this is a surgical opening in the neck into the trachea. It's also common for tracheostomies to be obstructed by mucus and require suction. Ventilators, we'll talk about those coming up. Insulin pumps on AICDs. But this little guy, this is a G tube. So when I get to this, there's an NG tube and a G tube. So this is what a G tube would look like. I should move this whole thing down to the tubes, but tracheostomy tubes. This is an opening in the neck called a stoma. Patients, these tracheostomy patients can range from newborns to elderly, can be any age. So this is a surgical opening in the neck called a stoma. A short breathing tube and flange is inserted into that stoma, and the patient breathes through that instead of their mouth and their nose. They're actually breathing through the hole in their neck. These patients may or may not be able to speak. Some patients can cover the tube and briefly speak with a speaker valve attached to the tube or an electric box applied to their larynx or their voice box. It just depends on where the surgery was placed. A frequent problem associated with tracheostomy tubes is the buildup of mucus in the tube. So suctioning may be needed on a regular basis to keep the tube clear, especially during time of distress if the patient has a respiratory infection. A patient with tracheostomy requires extensive care. Caregivers are provided with substantial training, including suctioning the tubing. They may also be familiar with changing and replacing of the tubes, which we're not going to do as first responders. That we're not trained to do that. Ventilators breathe for the patient. They range from in weight and size from small portable ventilators to large ones. The ventilator in this room is this little white box right here. There's some that are huge, like the size of this dresser. It just depends on what kind of ventilator they're attached to. The ventilator is attached to a ribbed tubing called ventilator circuit and attached to a tracheostomy tube. So this is the circuit tubing going around here, and then this is the stoma opening where it's attached at the trachea. Although the patient is dependent on that ventilator to breathe, they may still lead a relatively normal life. You may be called for a variety of reasons regarding ventilator-dependent patients. As with patients with a tracheostomy tube, suctioning these patients frequently is pretty common. Mucus plugs may become lodged in the tube and lead to lung infections, respiratory distress. At home, ventilators are powered by AC current, so in the event of power failure, the ventilator will only operate for a short period of time on battery power. So if we have like power failure in town, a lot of times fire departments start getting called out to start generators and stuff for these patients, or they bring them to the hospital so they can be still on their ventilator and it working. So in the event of those power failures, we can remove this ventilator cord off right here, and your BVM, your bag valve mask, attaches right into there, and we can ventilate for these patients with a bag valve mask. So people who have diabetes may also have an insulin pump to help regulate their blood glucose level. This device is worn on the belt, is about the size of like a small cell phone or like an old school pager. A small tube is attached to the device, is implanted in the patient's abdominal area, allowing for delivery of insulin from the pump to the patient. The pump injects insulin into the patient at a predetermined rate and prevents patients from having to inject themselves with insulin. It just does it for them. There can be problems with these devices. I've seen that happen where they just get a big dump of insulin, that type of thing. But questions to ask these patients: what devices do they have? So these are all the devices that are out there you might run into. Implanted defibs. This is an AICD. This is an automatic implanted cardiac defibrillator. This is generally surgically implanted in the left upper chest. The right side of the chest is usually pacemaker. The left side of the chest is usually the defibs. So the AICD is designed to monitor the patient's cardiac rhythm and detect life-threatening rhythms. When it does detect a life-threatening rhythm, it sends a single high energy shock delivered right to the heart of that patient. The patient may describe the extent of the pain as a shock as like a 6 out of 10 on the pain scale, somewhere in there. If the single shock does not occur or does not correct that rhythm, they're going to receive subsequent shocks after that. You may see the muscles twitch in the patient's chest as they're shocked, but it's not going to harm you if you're contacting the patient because it's going right to their heart. It's not like putting an AED on them. Patients usually are directed to call their doctors if they feel fine after a shock. If they have symptoms like they're dizzy, they're having chest pain, shortness of breath, or they're shocked more than twice in a 24-hour period, usually they got to go in to the hospital or call 911, go get checked out. There's the LVAD device, the left ventricular assistance device. So in cases of left-sided heart failure, a patient may need a heart transplant. This is what they use while they're waiting for that. So the left ventricle, like the bottom left of your heart, is your workhorse, right? Your left ventricle is the thing that pushes all that blood out. Well, that's not working in this case. So you have left-sided heart failure. So that left ventricle isn't working. So while waiting for a donor heart to come available, an LVAD serves as a bridge device for these patients. The LVAD takes blood from the left ventricle through an inserted tube, sends the blood to a pump implanted in the abdominal area. It pressurizes the blood like the left ventricle would do, and then it sends the blood out to the aorta to transport it to the rest of the body. External tube from the abdominal area is connected to these external battery packs and a control panel. So if you see somebody with these battery packs, don't take the batteries out, don't unplug them. You're just going to stop their heart. So we want to leave this stuff plugged in. All of that stuff is working as their heart right now. All right, feeding tubes. Patients, there's two different types of feeding tubes. So a feeding tube is used on patients who are unable to feed themselves or they can't swallow. This may be short-term during recovery from surgery or long-term for chronic conditions. So the two types of tubes that are out there is a nasogastric or NG tube. This one's inserted through the nose and into the stomach. This is primarily for short-term tube feedings. And then that younger kid I showed you with the tube going into his belly, that would be a gastric or a G tube. They're surgically implanted through the skin of the abdominal area and into the stomach for long-term use. So those are the two types that you'll see. Indwelling catheters. Some patients you encounter may have a central IV catheter. Patient who requires frequent IV therapy like chemo, they might have one of these catheters inside them. It's inserted surgically in the hospital, prevents the patient from suffering multiple needle sticks to receive medications for those long-term kind of illnesses. The indwelling catheter may be found usually in the chest wall because it's going directly into their heart in either arm or implanted under the skin. It depends on what they're using them for typically. The urinary catheter, so that's the indwelling catheters, right? This is for blood. Not blood draws that we can't use it. It's only for doctors to use. This is different than a urinary catheter. So urinary catheter is used for patients who have lost the ability to urinate or lost the ability to regulate when they urinate. Most catheters are inserted into the bladder through either the penis or the urethra opening. They use a balloon that they blow up and tubing to hold it inside. The external tubing is connected to a collection bag, usually like one of those round bags, or they can have a leg bag strapped to their leg. Or like the bigger ones have like a down drain so you can empty them. So they're not doing these as much as they used to do because infections. It's a very like especially females are very prone to infection when they get these. So they're actually using these when they have to. Like if somebody has a broken hip or something like that, they'll put one of these in. They're actually, I don't know if you guys have heard of these. They're using those PureWick devices. Looks like a little canoe that you kind of stick in between their legs, and it's attached to suction. And when they pee, it kind of collects in that, and it keeps them dry without having to put these in. So those are getting pretty popular too. We've transported a few people with those. Ostomy pouches. You may encounter patients who have an ostomy pouch or an ostomy bag. Ostomy pouches are connected to a section of bowel that is surgically pulled up through and attached to the abdominal wall for fecal drainage. An ostomy pouch is usually attached to the patient's leg or to the abdominal wall and is not visible under clothing. So you'll see that on some of your patients. And as abuse, as an EMR, we've talked about this already in the last couple chapters, but we may encounter or suspect the patient being abused. Abuse can take many forms: physical, sexual, emotional, financial, can be neglect, can be against any age or any sex. As a first responder, we are a legal requirement to report. Appropriate documentation is an essential part of this when handling these suspected causes or situations. Too often we focus on physical abuse because it's the easiest to see. But remember, physical abuse comes in other forms too: sexual, emotional, financial, all of that stuff. So if we're suspecting any of that, we need to say something. So again, physical, sexual, emotional, financial abuse, and then neglect. If we suspect any of this, document it well, document it objectively. Don't put your opinion on it, just put what you observe. Both suspected findings as well as the actions of the patient, caregivers, family members. The patient may be frightened to answer questions about the cause of injury, have vague or conflicting stories, not answer all of your questions. The caregivers may also prevent the patient from being interviewed or assessed without them there, or attempt to prevent the patient from answering questions at all. So if we're suspecting this, never confront the accuser, the caregiver, guardian, family member of the abuse. Some medical disorders and cultural beliefs mimic abuse, but may be considered so. Physical, this stuff we need to pass on. Physicians and abuse specialists are best qualified to do this in a neutral, non-confrontal environment. But we need to report it. So in most states, as a first responder, yes, we in Minnesota are legally obligated to report these. In addition to individual state reporting systems, we want to document our findings, like I was saying, in your patient care report. Just be objective when you're doing it. All right, terms. Palliative care is a type of medicine that is concerned with providing comfort care for patients with terminal illness. Hospice is a community-based organization that provides palliative care for terminally ill patients. A living will is a document in which a patient can make known their will in regard to advanced life support measures in the case that they become seriously ill or injured. Tracheostomy is a surgical opening placed in the front of the neck in a trachea where a tube can be placed and provide an airway for a patient who requires long-term mechanical ventilation. A ventilator is a mechanical device that provides positive pressure ventilation to patients who are unable to breathe on their own due to disease, spinal cord injury in a home setting, usually used on patients who have a tracheostomy. An insulin pump is a small device about the size of a cell phone or pager that provides a constant flow of insulin to an insulin-dependent diabetic. This allows them to live a normal life. AICD, or automated implanted cardiac defibrillator, is a small device that is implanted in the patient's left chest to monitor the electrical rhythm of the heart and provide a shock to reset the heart into a normal rhythm if needed. LVAD is a left ventricle assistance device. It's a temporary external device that can assist a weak or failing heart to pump blood until a donor heart can be found. Indwelling catheter is a surgically implanted IV catheter for patients receiving long-term IV medications like chemo. Way different than the urinary catheter. A tube is placed in the bladder to drain urine, right? Nothing to do with blood. Ostomy is a surgically created hole where urine or feces can be eliminated from the body, and there's usually a bag attached to that, so you don't want to pull on that. Physical abuse is unexplained bruises, especially in various stages of healing: broken bones, welts, burn marks, bruises in the shape of objects like irons, cigarettes, hitting, shaking. Sexual abuse, rape, or inappropriate non-consensual sexual touching. Signs include bruising or trauma around the genital area, anus, torn, stained, bloody undergarments. Emotional abuse is threatening, bullying, insults, harassment. And then you have neglect, which is malnourishment, dehydration, inappropriate clothing, soiled diapers, unsafe living conditions, soiled bedding, poor personal hygiene is all considered neglect. All right, you respond to a call for help and find a 49-year-old female patient in cardiac arrest. The patient has terminal cancer and her husband presents you with a DNR. Let's say the DNR is signed. We should what? We should withhold CPR, right? We need to honor that DNR in our state. One of the best sources of information on a patient with congenital illness is the patient's family member. Don't dismiss the family members or caregivers in certain circumstances. They can really help you out. Someone suffering from a terminal illness may have a blank to guide family about their wishes if she or he becomes unable to make decisions. Living will. And last one, if your patient suffered a spinal cord injury and now has a surgical opening in the neck, tracheostomy, right? That's our surgical opening in the neck, called a stoma. All right. How we doing? Feeling good?
And Dandy.
I'm going to pause this.